All right. Well, hello, everyone. Welcome to our live talk on conservative treatment options for low back pain. Tonight, I'm going to take a second to explain our format, but with us this evening, we have Dr. Judith Lee-Sigler. As I've already said, to keep background noise down, we ask that you mute your speakers, your mics, and if you become unmuted, we ask that you do remute yourself. We are encouraging you to ask questions and interact with us during this webinar. If you'd like to submit your questions via the Zoom chat feature, you can do that and I'll read them at the end of the presentation. I've also received a number of questions ahead of time and I'll start the Q&A session with those. Now, a brief introduction about Ortho South. We're a comprehensive orthopedic care clinic and offer care at 7 locations in the Mid-South region. We have surgery centers in both Germantown, Tennessee and South Haven, Mississippi, and are proud that our Germantown Surgery Center was recently ranked in Newsweek Top ASC in America. We have Saturday clinic hours in Bartlett, evening hours in East Memphis, and a 24/7 urgent care triage line for those after hours injuries. And now let me introduce our speaker. Dr. Lee-Sigler is a fellow of the American Board of Physical Medicine and Rehabilitation. She is a veteran of the United States Air Force, which includes service in Saudi Arabia during Operation Desert Shield and Desert Storm. Dr. Lee-Sigler served as the medical director of the Carl Spine Center Therapy Services and Inpatient Rehabilitation Unit before moving to Memphis, where she practiced at Memphis Spine Center before joining Tabor Orthopedics. With over 20 years of clinical experience, she specializes in non-surgical spine and orthopedic medicine, diagnostic and therapeutic injections, regenerative medicine techniques, spinal column stimulator trials, electromyography and nerve conduction studies, and Botox therapy for migraine headaches and torticollis. So now I invite you to sit back and relax and enjoy Dr. Lee-Sigler's presentation. Without further ado, take it away, Dr. Lee-Sigler.
Thank you for joining me to discuss conservative treatment options for low back pain. I will start by discussing initial management, discuss the difference between a back strain and a back sprain, discuss risk factors, when to seek medical treatment, review what one can expect in the medical evaluation and initial treatment options. I will then go on to discuss evaluation and treatment of recurrent or prolonged low back pain. The initial management may include relative rest, and remember, bed rest should not be required, and if so, please try to keep it to a minimum. Oral anti-inflammatory agents such as Aleve or ibuprofen, but if you're on blood thinners or you have a history of ulcers, kidney disease, significant heart disease, or blood pressure issues, you should avoid these unless you have permission from your primary care physician or whoever is treating you for this condition, and use Tylenol as your oral agent. If you have liver disease, you may need to avoid Tylenol too unless you have permission from your treating physician. Some examples of topical agents include Biofreeze, capsaicin, lidocaine, icy hot, Aspirin cream, Voltaren gel, arnica gel. You can use ice for acute injury, 15-20 minutes on, 15-20 minutes off, followed by heat. Over-the-counter TENS units, and that's what's depicted here. Short-term use of a brace, muscle relaxers, stretches. A strain of the back is an injury to a back and or supporting muscles, and the most important back supporting muscle are the abdominals. A sprain is a ligamentous injury, so ligaments connect one bone to another bone. A joint injury, like the facet joint, or what people commonly call a Z joint, they connect one level of the spine to the next level of the spine. The annulus of the disc, which is kind of a thick tissue that surrounds the gel-like center. In the case of a sprain of the annulus, the substances can leak from the gel-like center and cause inflammation and irritate nerve roots. And that can happen even without having herniated the disc. Just a sprain of the disc can do that. Risk factors. So lifting an item that's too heavy for the person's strength or fitness level. And sometimes the item lifted isn't even that heavy, but the angle may be awkward, or the person's posture, body mechanics, etc. may be such that the injury is created. Other things that put a person at risk include operating vibrating equipment, sitting for long periods of time, especially if the chair setup is not the best for the person's body, a mattress that is too soft, wearing a poorly fitting backpack. And we've all slung backpacks over our shoulders and carried it all on one shoulder. And we know that backpacks really aren't meant to be worn that way and can injure your back and shoulder if that occurs habitually. You may run a higher risk of low back pain if you're not physically fit, if you don't have enough strength for the activities that you are or have been doing. And remember that more than just upper body strength is needed. If you don't have good flexibility, if you're not paying attention to your body mechanics, meaning how you position yourself to do an activity. So I find that earlier in people's careers, their injuries often occur because they haven't incorporated good habits. They haven't been trained properly, or they haven't been able to incorporate that training such that it's a habit. Later in a person's career, it normally occurs because the person no longer has the strength or flexibility to do what needs to be done. They know how to do it, they're just not able to do it as well. When to seek medical treatment. When you've done all of the above regularly for a few days and you're not improving or you're worsening, if you develop pain, tingling, numbness that radiates down your legs, particularly if those symptoms radiate past your knees, if you think you may have a fracture, if you have numbness in the genital area, if you have fever, chills, or sweats associated with it, and if the pain is much worse during the night. If you're developing weakness, there's a loss or significant change in bowel and or bladder function. The medical evaluation is going to include the history, examination, and imaging at certain times. So be sure to communicate the critical information, and I call them the W's, and those can be communicated in a short period of time and kind of help focus your appointment so that you get the most out of it. So where is the pain? When did it start? What is the severity? What makes it better? What makes it worse? Why do you think you developed the pain? What has the treatment been so far? Things that you've done at home or other, things that have been suggested to you. What's been the result and who referred you? X-rays may be ordered. They can be helpful in identifying a fracture or slip of one bone on the other, as well as identifying arthritic change and giving clues about degenerative change. But keep in mind that the finding may not be the cause or main cause of the symptoms. It's important to take your medication directed if you're prescribed medication. If for some reason you cannot, you have side effects, or you're concerned about side effects, notify the doctor. Try not to just stop taking the medication without letting the doctor know and giving him or her the opportunity to change the medication or maybe give you some different instructions. How can physical therapy help? So first of all, they generally do a really good physical examination and determine areas of tissue restriction, directional preference. So directional preference is when you go in one direction and the symptoms get worse or go further down your legs, or you get tingling or numbness down your legs. You go in the other direction and those symptoms go back into your back. So for instance, you've been forward and the symptoms start to radiate down your legs. You kind of put your hands on your hips and bend backwards and they get better. Your directional preference is going backwards. They'll design an exercise program based on this directional preference and to increase key muscle strength, as well as help you reduce tissue restrictions. Modalities such as interferential heat, cold, e-stim, in combination with stretching, manual therapy, dry needling, etc., may be of benefit as well. And make sure you go over the treatment plan with the therapist so that the treatment plan is carried out. Sometimes a therapy assistant will be carrying out the plan, and you want to be sure you know the plan so that you know that it's being carried out. If you're having more actual pain, not just muscle soreness after the exercises, be sure to let your therapist know so that he or she can kind of drill down on the problem and make the appropriate adjustments. I generally find that lack of compliance with physical therapy is often secondary to a lack of two-way communication. That is an image of dry needling, and lots of times that can be incorporated into your treatment plan. After the initial phase comes the return to activity phase, and this involves a gradual return to activities and weaning of meds. It's important to prevention of recurrence that this occur in an organized, coordinated fashion. So lots of times you are continuing to heal, but your pain has gotten significantly better. That's not the time to stop doing your exercises and stop doing the things that helped. Recurrent or prolonged back pain. If pain, tingling, or numbness is recurrent, weakness or other worrisome symptoms develop, advanced imaging such as the MRI is warranted. Remember that MRI findings or CT findings for those who are unable to have the MRI will have to be correlated with your symptoms. Sometimes things are seen, but they're not causing problems. Also, there are times when the symptoms are much worse than or do not match the findings. In this case, more like electrodiagnostic testing that you see here, commonly called EMGs, or other imaging or labs may be warranted. Treatment at this point can involve some or all of the following. So physical therapy may be more directed at this time now that you have more information. Development of a different or better home exercise program, dry needling, acupuncture, forms traction, chiropractic care may be incorporated or changed if you were already having it. A word about injections. So we commonly call lots of different types of injections blocks. The target, method, and medicine injected are important, as well as whether or not the injection is diagnostic or therapeutic. We don't expect you to know these things, but it is helpful if you gather all that information and make sure that we have it so that we know what you've already had and know what our starting point should be. Trigger point injections are usually best used in combination with physical therapy, and these are often done in a series. Facet joint injections, again, those joints that connect one level of the spine to the other. Epidural steroid injections, they're different types. So what you see here is an example of an interlaminar epidural steroid injection. Then there are transforaminal epidural steroid injections, which will be on the next slide. There are caudal epidural injections. And then there's a sacroiliac joint injections. Those injections occur in the joint that connects the back to the hip, and that can be an important, often overlooked cause of back pain. Diagnostic injections include medial branch blocks and selective nerve root blocks. Advanced procedures, radiofrequency ablation. This may be offered if the history exam and data indicate that the facet joint and its nerves are the cause or significant contributing factor to your problem. Also, facet joint and medial branch blocks must occur first to confirm that the radiofrequency ablation will help. This is a minimally invasive procedure that's performed at a specially equipped doctor's office, a surgery center, or a hospital. The patient returns home the same day. The target nerve is identified using a fluoroscope and by placing an active electrode through each needle and giving a small current that's usually not painful to be sure that the needle is next to the target nerve and at a safe distance from other nerves. A heat lesion is created on the nerve using the preferred method so that the nerve does not transmit pain. Spinal column stimulation. This treatment can be used for chronic intractable pain of the spine and or limbs caused by a variety of conditions, and the FDA has just approved spinal column stimulation for diabetic neuropathy. After at least 6 months of other conservative care and determination that surgery is not the more appropriate course of action, this may be offered. It can also be offered when surgery has occurred but has not been successful in alleviating symptoms. A trial will first occur during which a lead wire or wires are placed behind the spinal cord in the epidural space. This wire or wires have electrodes that can be programmed to generate an electrical field to block pain by blocking nerve conduction of painful signals. While some units feel, in particular the older units, feel like a TENS unit, newer devices do not. They just block the pain. The device is programmed remotely, and the patient has programs put in place that he or she can use. If a trial is successful, the device can be permanently implanted. Orthobiologics, commonly called regenerative medicine or stem cells or PRP, is the placement of one's own signaling cells from the bone marrow, or less commonly fat and or growth factors from the peripheral blood, meaning drawn through your arm, into an area of injury, such as a tendon. Tendons connect muscle to bone, or a ligament. Ligaments connect bone to bone, into a degenerated joint or into the disc itself to promote healing, pain reduction, or improvement in function as appropriate. I just want to leave you with some thoughts before we start questions. And one is to be aware that hip problems can mimic spine problems. So it's important, particularly if you're not getting better, to have the hip evaluated as well. Don't underestimate the importance of becoming physically fit, and this includes strength, range, aerobics, posture, and ergonomics or body mechanics. Once you improve or are well, continue doing the things that helped you. And remember, just because it's over the counter does not mean it's safe. You need to check with your doctor if you have other health conditions that could be affected. Thank you.
All right, thank you, Dr. Lee-Sigler. So as I previously mentioned, we have some questions that were submitted ahead of time. So I'm going to begin with those. Everyone, if you have a question, please feel free to submit it via the Zoom chat feature. All right, Dr. Lee-Sigler, first question. I am 82 years old and generally in good health, according to my general practitioner. Lots of exercise, yard work, etc. I have lower back pain in the morning that's almost incapacitating. Most of my friends my age have the same problem, but I don't know if they exercise. I've reached the conclusion that it's just part of the natural aging process. Is that the case?
This may or may not be the case. Sometimes stiffness, and the stiffness could be quite significant, may occur as part of the natural aging process. And this is usually helped by stretching before you get out of bed or performing certain stretches before you get out of bed. But if the pain is really excruciating or incapacitating, in my opinion, it's worth having an evaluation, because you may find that there's something that is more treatable, for instance, the facet joints or other problems that could be evaluated.
Alrighty, next question. I have back pain when I work in the kitchen for more than 10 minutes or so. It's relieved if I lie flat for a while, and I've tried standing different ways, but nothing seems to work. If I succeed in stopping the pain in one place, it starts hurting somewhere else. I recently got a nerve block, but I would like to know if special shoes would help. I've noticed that higher heels force a difference in my stance.
Oftentimes when people have degenerative disc disease, it's pretty classic for them to say when they're standing and working in the kitchen, they have an increase in pain. Mats that absorb pressure, so those pressure absorbing mats can be helpful. A change in shoe can be helpful, particularly if you're used to wearing one type of shoe. Just changing the way that the gravity moves through your body can be helpful. So it is true that a change in shoe, change in stance. Some people will open a cabinet door and put one foot inside the cabinet, have the other one out, and then switch periodically. Those things can be helpful. With regard to the nerve block, once again, it will be helpful to know what type was done and what the target was and what the expected outcome was, to know if there's another option for you.
All right, thank you, Dr. Lee-Sigler. Now, the next couple of questions are applied for steroid injections and or ablations. How many types of steroid injections and or ablations for the lower back are there, and what is the difference in them?
So the types of steroid injections for the low back include the epidural steroid injections, and those include the interlaminar approach. Those are often used when the low back pain is more severe than the leg pain, or they're fairly equal. Sometimes they are done when there are several levels that need to be addressed, and it's not reasonable to address all those levels at one time, or insurance will not pay to have all those levels addressed at one time. Transforaminal epidural steroid injections are often used when the leg pain is greater than the back pain, but they can also be used when people have had surgery at a level so that it's not practical to enter through that space, and the interlaminar space. Again, the interlaminar space, as you saw in the picture, if you touch the bones in your back and you go just off to the side, just a tiny bit, that's really where the entry point is going to be for the interlaminar space. A transforaminal space is going to be much further off to the side. You're still entering the canal just as the images showed, but from a different angle. And typically one will see the nerve root as it comes out. That's generally done when one knows the level that they want. They know or see that there's nerve compression, or that it appears that the disc may be affecting one particular nerve on one side or the other. And sometimes it can be more than one level, but generally only two levels there are done at a time. The caudal epidural steroid injection is really the first epidural steroid injection that was attempted or developed. And that's where one enters the epidural space at the very lowest point where in the spine, and then the needle is advanced up, and then the nerves are kind of showered with anesthetic and medication. That is frequently used when the person has either multiple levels, they have such severe compression of the spaces that it's not practical to get in the interlaminar space, or they've had prior surgery or fusion, making it impractical to enter at a particular level. And then there's the facet joint injections that I discussed, and then those can lead to the medial branch blocks. Then the radiofrequency ablation. There are the sacroiliac joint injections. And then there are other like targeted trigger point injections like the piriformis, which is an often overlooked source of back and leg pain. secondary to its proximity to the sciatic nerve. And then there's other injections like the quadratus lumborum, or what people will call QL or QL syndrome. Those are the major types of injections.
Yes, ma'am. Thank you. All right. Next question. What are the side effects of having numerous steroid injections and/or ablations?
Okay. So generally, steroid injections have been tested out at 3 to 4 per year and found to be safe for most people. Now, there are some important things or caveats to that, and that is for people who have diabetes, particularly if their diabetes is brittle or difficult to manage. Steroids are going to increase your blood sugar, and for people who are kind of on that edge or who aren't well managed, or even if you are well managed, they can increase your blood sugar. Over time, particularly given the site of injection, there can be death of tissue in that area, so death of some of the fat underneath. It can be toxic to joints if repeated many times. However, if those times are spaced out, then things are then it's tolerated much better. And that's why for many folks, that number is limited to 3 to 4 per year. In days past, and people have different protocols for how they will do things. Some doctors will say, well, we can do it every 3 months. That's usually for something that's a bit more chronic, or if you know the person has results that last that period of time. For other people, particularly if you have a severe problem, so let's say the person has a large disc herniation and it is putting pressure on the nerve, and the person does not want to have surgery, it's not feasible for them to have surgery, or they just really would like to avoid it or see if they can get better without it. One may stack the injection so that you do 1 or 2 weeks out or apart from each other, and then see how the person does. So the protocol varies depending on the person's problem, and sometimes it varies depending upon the physician's practice, how they like to do things.
All right, next question. After about 10 minutes of standing, my lower back radiates so much pain I have to sit down immediately. What can I do to alleviate this?
If the pain is radiating, but it's radiating and staying in your back, then that generally means there are 2 things that will generally cause that. One are the facet joints that we talked about, and those can be evaluated and addressed. The other is sometimes a disc that is herniated, but herniated way out to the side. Sometimes in those cases, the person really doesn't get leg pain, but standing will really bother them. And then there's a third thing, and that is spinal stenosis. That's when the spinal canal is starting to close off. So anytime a person bends forward or leans forward, that will generally tend to alleviate things. And so the whole exercise program has to be based on that, strengthening the core and coming forward. Certain types of injections can be helpful, but the decision there has to be made between a problem that's in the spinal canal, a far lateral disc herniation, or the facet joints as the cause. And so lots of times the examination is helpful with that. And sometimes people have to do what's called a differential blockade. So you see multiple issues, they fit the exam, and it's very difficult to tell which is which. That's when one may address the facet joints, the person keeps a pain diary, or one may address then by interlaminar approach, the epidural steroid injection, to determine what should be done from there.
Thank you, Dr. Lee-Sigler, and I believe we have one more question. I have reoccurring flare-ups of back pain related to bulging disc in my lumbar spine. I have a hard time, oops, sorry, someone sent another one, so I lied about that. Let me scroll back up. All right, I have a hard time timing when I'm supposed to make an appointment and come in versus trying to manage with Aleve. Is there a good way for me to tell when it's time to go in?
I generally have most of my patients set a pain threshold level. So when we talk about a pain scale, we usually talk about a 0 to 10 scale. 0 is no pain. 10 is called the ambulance pain. So 10 is not severe pain. It's called the ambulance pain. Usually people can manage pain when it's a 4 and below. So 4 or 5 and below, that's when people, it's there, they know it's there, they can manage it. 2 or 3, they can manage it generally significantly well. Once it creeps up to a 4 or 5, it tends to be on the person's mind all the time. It takes up their energy. They have a hard time concentrating. That is generally the point when you need to go in. Somewhere between that 4 to 5 range And you need to establish that for yourself. Sometimes I have people keep it. It just takes, a few seconds a day to do it. I have people keep a diary for a period of time so that they get used to their own, what is your 2, what is your 4, what is your 5, so that you know what that is, so that you know when you cross that threshold, that's the time to go in.
All right. Thank you, Dr. Lee-Sigler. Now, this isn't necessarily a question, but I'm going to read this to you, and we'd like to hear your comments.
Okay.
I saw a type of TENS unit being sold on TV by another doctor. Having worked out for decades in gyms, I'm a believer in controlled strength training more so than some of the passive machines that just vibrate or tense muscles. However, since the back extension machines and rowing machines in the gym are limited in their focus, I wonder if a machine like the one on TV has benefits since it can target a more specific area of the back, or if it's also more dangerous for that same reason.
So I think you're talking about the E-stem machines where you put them on certain muscles and they help you strengthen that particular muscle group. And those have been relatively controversial. So generally speaking, we use them therapeutically, particularly when people have atrophy, the dying away of certain muscles, either from surgery or it died away from an injury, that sort of thing. The time that you use that, though, is targeted. I think that if you're already a strong person and you're using it to help train a particular area, it's okay to use it for a brief period of time. But what you want is your own muscle to take over and your own, neurotransmitters to take over your brain muscle function to connect and take over. Other than that, if you're just using it for a short training period, if you're using it because you have atrophy someplace, then that can be a reasonable thing to do.
All right, and then we were sent one more question. Is there any sort of correlation you've seen between chronic back pain and mental health problems? And if so, what do you do or look for on the orthopedic side?
Yes, so there are correlations between chronic back pain and mental health problems. And sometimes it's a chicken and situation. So when a person has chronic pain for any reason, it can tend to affect their mental health. They can become depressed, they can become anxious, they can become worried, that sort of thing. And on the other hand, if one is chronically depressed, they may not take good care of themselves and do the types of things they need to do to keep their spine strong, making themselves more prone to injury. The things that we look for on the orthopedic side are complaints, or when the person is reporting symptoms that are out of the range of what we can see on all of the testing. And I don't just mean MRI. So you always delve deeper to see if there is something there causing the problem that you've not yet determined. We don't just assign it necessarily to, oh, you're depressed, that's why. But there are some questionnaires and screening tools that can be used to help when that's being suspected. And so sometimes one will be referred to a neuropsychologist. Sometimes in the therapy and other questionnaires that we give you, there'll be some questions that give us clues to that. And if the person is having chronic pain, so one is seeing a person over and over, it is important to ask them, if they don't volunteer, do you find a lack of energy? Do you find that you don't want to get up and do things? Do you find that you can just ask the question, are you becoming depressed because of this? Because there are some medicines that do treat depression, but also treat the pain, but also sometimes counseling and other functional therapies are needed.
All right. Thank you, Dr. Lee-Sigler. Thank you for your presentation and for taking the time to answer our questions. Everyone, I hope you found Dr. Lee-Sigler's webinar informative, and this webinar will be available online at www.orthosouth.org in the next couple of days if you'd like to watch it again or refer back to one of the questions Dr. Lee-Sigler answered. Thank you and have a good night.
Thank you.